And it's my great pleasure to welcome Ian Martin as our opening speaker. Ian's a upper GI surgeon based in Brisbane who has a vast amount of experience at obesity surgery and correcting other people's obesity surgery. And I'd like to welcome him to give us a walkthrough about the surgery around obesity. Thanks, Ian.
Thanks, Phil. A lot of those corrections were probably from my own surgery, but we'll just move on. As you can see, we've certainly evolved with time, and unfortunately 10% of Australians now are obese, and that's nearly 3 million people, and no developed country has been able to change the tide of the increasing obesity epidemic. Despite the fact that mortality rates escalate with BMI. If you look at this laser pointer here, normal BMI is 20. If you go up to 35 and then 45, you'll see that mortality rates increase up to threefold, looking at a cause-specific mortality evaluation of 900,000 patients. So with death rates incrementally increasing, and if we look at the risks of other comorbidities on a population of BMI 40 patients, you'll see that the relative risk of type 2 diabetes, lipidemias, sleep apnea, breathlessness, intracranial hypertension, 2 to 5 times the risk of all-cause mortality, stroke, endometrial cancer, gout, breast cancers, obstetric complications, reflux, and not the least anaesthetic risks all go up in the obese population. And despite the fact that diabetes, which is the biggest cost to our health dollar medically today, increases exponentially as the BMI rises from 25 to 35, and the obesity average obese surgical patient is 45, you see that in women, this yellow line of age-adjusted relative risk of diabetes goes up quite markedly. Interestingly, when your BMI increases only 5 points, this beautiful paper in The Lancet showed that all causes of cancer rise significantly as well. And in fact, you look at the risk ratios: esophageal, thyroid, colon, renal, liver, melanoma, rectum, gallbladder cancer, pancreas cancer, non-Hodgkin's lymphoma, they all increase markedly with weight. The only two here on the left side of the equation are SCC lung and esophageal SCC because of smoking. And now we know that obesity has a direct causal effect as powerful and potent as smoking. So we're now looking at these patients that we'd consider for surgery. Most of us would consider this normal, but in fact BMI of 30 is obese, and these patients are physiologically still sick. So why is it that every diet and every form of drug and behavioural modification lasts beautifully for 6 months, yet we all rebound back after 1, 2, 3, 4, 5 years to be heavier than we ever were before? We see that every day of our lives. Why is it that these patients cannot maintain their weight down? Because we know that only 3% of the population can keep their weight down for 2 to 3 years. Is it that the 97% are inherently lazy or eat too much, or are there other phenomena that are to play? We gave a lecture to a conference of 500 GPs last year and asked them whether they felt that obesity is a behavioural problem. Most agreed. We asked the GPs whether non-surgical treatment of obesity is more effective. A mixed bag of responses. We asked the GPs whether diet and exercise is the most effective strategy, and 80% agreed. So let's look at the literature and see whether the doctors in our community are correct. And if we look at our NH and MRC governing body from last year, looking at all the evidence provided for diets, low energy, very low energy, or meal replacement diets, at 1 year you do get significant weight loss, but small. And after 2 years, that's for those that remain on their dietary schedule. Remember, there's a 90% attrition rate of all diets by 2 years. Meal replacement is the best way to maintain weight loss, provided you keep doing it for life. And the average weight loss is 6.5 kilos. If we look at physical activity at 2 years, weight loss of 1.3 kilos, and when diet and activity has been studied longitudinally, 3 kilos. If we look at drugs, the two most popular in Australia today, Xenical, Duramine, 6,929 patients over 12 months with higher attrition rates, weight loss against placebo 2.7 and 4.3 kilos. So we all can lose weight substantially for 6 months. It's maintaining intermediate and long-term results that has been the trick. And so if we look at the results of lap banding published, 34 kilos at 2 years, sleeve gastrectomy 40 kilos, gastric bypass 44 kilos, other forms of bypass more aggressive up to 50 kilos. So why is it that we seem to be able to, our hypothalamus seems to set our rate of weight, and no matter what we do, it tries to rebound us back to that level. And this gives us some insight into it. Mice only live for 200 days. And these black mice are controlled, and they've been given their normal diet. And these other black mice were overfed for most of their life, for 150 days before their natural senescence at 200. And you see, after they've been overfed 50% more calories, they still self-regulate back to a normal weight pattern that the control mice were given. Similarly, these white mice are control, and this lower line is those that were starved. They were given 20% deficient calories for most of their life until retirement age. And then they bounce straight back into fat or fatter than the other mice before. So it appears that obesity is centrally regulated and it homeostatically changes with time. And the next best study was in the New England Journal of medical students who were paid to fatten up and put on 10% of their weight. And they did. And this on the y-axis is their total energy expenditure or their metabolic rate. And you see, when you fatten up, your metabolic rate increases to try and drop your weight down to this centrally regulated, hypothalamically based mechanism. And in fact, interestingly, once they were made and paid to return to their normal weight, their metabolic rate actually fell, such that their new thermostat was set at a slightly higher level. Interestingly, if you starve yourself by being paid to lose 10% or 20% of your weight loss, look what happens to metabolic rate. It plummets. So because of hormonal factors, hunger factors, and metabolic rate factors, the weight rebounds back towards a standard line. That's highly suggestive that obesity is genetically endeavoured. And in fact, if you need to prove that, you need identical twin studies, and that's been performed. This beautiful study in the New England Journal of 12 pairs of identical twins were all overfed for 100 days. They were stuck in a house, they all ate twice the natural calories that they needed, and the energy expenditure was the same. Twin A or twin B and twin A each put on a certain amount of weight. These little skinny pair of twins, after 100 days, only put on 2 kilos. They ate the same amount as these fat twins, who each put on 18 kilos. So the weight difference between 2, 4, 6, 8, 10, 12, 14, 16, 18 kilos after eating the same amount of food. And we all see that in society today. But the fascinating thing is this is a linear plot, almost exactly linear, whereas brothers and sisters are scattered throughout that square. And it's a powerful suggestion that genetics plays a role. Our next speaker identified with his collaborators the gene that showed leptin deficiency in children, the first gene of many genes that are associated with obesity. And after giving leptin, the change in format in this young boy. So if we look at prevention and treatment of obesity, of all the 99 studies done, a systematic review of all randomised controlled trials, diet, exercise, behavioural therapy, drugs and surgery, the overview and summary platform statement was that childhood obesity, family therapy and lifestyle modification is pretty effective for treatment in the early stages. However, unfortunately for adult, surgery is effective. No other modality or combination showed a clear or durable benefit. So So who do we operate on? People that are really fat, BMI of 40 or 35 with associated comorbidities. Nearly all of them have had a history of a failed sustained weight loss program on a supervised weight loss or expensive program. They should not have substance abuse, psychosis, or uncontrolled depression. Wendy Brown and Paul O'Brien in Melbourne, the Monash Obesity Institute, two fabulous research surgeons looked at lap banding, which really gave it a name and a face with the science behind that operation. And they found at 2 years with the reduction in comorbidities of these things. Diabetes, 60% after banding were non-diabetic at 1 year, 26% improved control. Hypertension, 60% were normotensive off therapy. Dyslipidemias were all improved. Asthma, a third had no longer had asthma after surgery. Severity scores of those remaining went from 44 to 14. Reflux was largely resolved. A third had sleep apnea preoperatively, 2% at 1 year, and quality of life all improved and was sustained out to 4 years for those that had undergone an operation. If you look at fat people, they are depressed. If you measure it formally on the Beck Depression Index, which is really 21 questions covering all 9 of the attitudes and symptoms, which are DSM-4 criteria for major depressive illness, we'll see that normal is less than 10, and moderate is 15 to 22, and a major depressive illness is 23. And of their cohort of lap band patients, when they started at a BMI of 44, you'll see moderate depression levels in all fat patients. And under 10 is normal, and these patients' quality of life is improved significantly and it's sustainable. The same group did the first quality randomised trial comparing skinny fatties with a BMI of only 30 to 35 with one comorbidity associated with their obesity, and they compared diet versus lap banding. Purple is lap banding, and this is the percentage of excess weight loss. At 6 months, as we all know, diet and exercise works beautifully well. But unfortunately, because of this rebound, hormonal and metabolic consequences, weight regain is the norm. And this is because of OptiFast works just as well as lap banding for the first 6 months. It's because of trace element deficiencies that one can't keep going on drastic meal replacement therapy. We do know that if you do diet and your weight is, and you successfully, that you have to maintain 1,000 calories per day for life to maintain your weight at that lower level. That's like 3 small entree-sized meals a day. This is the Swedish obesity study, a fabulous overview, probably our best long-term results. It captures every obesity surgical patient in Sweden with their national registry data, and they had case-match controls of obesity cohorts of a further 2,000 patients that had not undergone the surgery and followed them for 15 years. And the results were this. The weight over 15 years on the morbidly obese with a mean BMI of 44 stayed the same over 15 years. And this is percentage of weight loss. Those that underwent laparoscopic gastric banding lost 15% of their body weight, 20% with an older operation called vertically banded gastroplasty, and 30% of their body weight for 15 years. So as you'll see, all surgical operations do really well, and like every other factor, they can increase in weight, but they stay much lower. They sustain long-term weight loss compared to matched controls. If you look at their survivability, including anyone who might die with surgery, because it's not a complication-free zone, that if you look at all causes of mortality, there were 129 deaths in the control group and 101 deaths in the surgery group at 15 years. So a meta-analysis looking at comorbidity resolution with obesity surgery showed that there's a reduction, this is with all weight loss surgery, around the world of diabetes, complete resolution in 60% of cases, hypertension in 60%, hyperlipidemia is improved in 70%, obstructive sleep apnea is resolved in 80%, premature death is reduced significantly, and improvements in quality of life, less depression, greater mobility, fertility, less incontinence, and more potency. And although it appears expensive relative to other treatments, there are numerous papers including our NH&MRC body that quotes that it's the most cost-effective treatment available for a weight reduction. This is a randomised controlled trial of lap band versus conventional therapy for diabetes, the most costly complication of obesity. And in this trial by the Melbourne group, diabetes was complete remission in 72% of surgical patients, 13% of conventional group at 2 years, with a weight loss of 20% of total body weight at 2 years with banding and 1.7% in the conventional group. This is a more aggressive study. Similarly, a more recent randomised controlled trial in the Cleveland group of 150 patients randomised to intensive medical therapy. They're all diabetics. Intensive medical therapy with sleeves or gastric bypass. These are more robust operations generally, and their primary endpoint was proportion of patients with a glycosylated haemoglobin level of 6% or less at 12 months after treatment. And if you look at these results, you'll see that with medical therapy, 12% still have a low glycosylated haemoglobin level that they tried to achieve, whereas it's much higher in the bypass group or the sleeve gastrectomy group. And when they looked at the number of medications used, sorry about the clarity of this slide, the number of medications went up in the control group to 3 medications, down to half or 1 medication per average on the operation group. The International Diabetes Federation also has put out a formal position statement in 2011 saying that surgery should be an accepted option for type 2 diabetes and a BMI over 35, and it should even be considered in those with a BMI of 30 to 35 because of randomised trial evidence of improvements. Particularly the Indians and the Chinese and other ethnic races have the metabolic syndrome at much lower BMIs compared to the Caucasian population. Morbidity and mortality of bariatric surgery is generally low, equivalent to elective gallbladder surgery, and that bariatric surgery in severely obese with type 2 diabetes has a range of health benefits and all-cause mortality. You, being anaesthetists, you all know the operations anyway. There's the lap band, which is decreasing in Australia in its prevalence down to about 20% of all operations. The sleeve, which is having a honeymoon period, about 60% of all operations, and the bypass, which is increasing, about another 20% around Australia. The band's the safest, it's simple, it's easy, but has a higher reoperation rate and a removal rate. The reason being is that these things artificial devices can slip or they can erode, and the tubing can fray, and the port sites can flip. So a higher reoperation rate, still very safe, effective in randomised trials for diabetes and excess weight loss. The sleeve gastrectomy is more popular because it imparts a huge risk to the patient of leak along the staple line, which is still only 1%. And if the patient leaks, they have significant morbidity. They can even die. They can be in hospital for a long period of time. But of the 98, 99% that don't leak, they have a pretty stress-free existence for a long time afterwards with significant weight reduction. They do have mild iron deficiency because of iron's absorbed in the stomach and B12 deficiency, and multivitamins are required and vitamin B12 blood tests annually. But that's it from a metabolic point of view for the sleeve gastrectomy. It's why we fundamentally like it, provided we think the patient could survive a leak from the staple line. The bypass, which is restrictive, giving the patient a small pouch and this little Roux-en-Y connection here, is the gold standard, probably gives the greatest weight loss, fractionally so more than the sleeve. However, it does have hormonal and metabolic effects, mainly through GLP-1, but the problems down the track are this little join here imparts a 2% risk per annum of life-threatening intestinal obstruction, which is not always detectable on a CT scan. And there are significant requirements for vitamins and trace element replacement for life, and therefore this is considered a more radical procedure than the sleeve gastrectomy. So many people around the world are adopting a sleeve gastrectomy and moving on to bypass or more radical procedures down the track. Having said that, the most research and the longevity is proven for the bypass more than other operations. Randomised trials of the Roux-en-Y gastric bypass versus gastric banding have been performed. This was a case match study of 442 patients, showing that there is more complications in the Roux-Y gastric bypass major, 3.6% to 2. There were no deaths in this study. At 3 years, however, there was a failure. We call a failure less than 25% of your excess weight loss, in 18% for the band, none for bypass. That's the trouble with the band, and that 21% of the band, or a fifth, were removed by 6 years. So that's the issues we have with an artificial device. It's safe, it's good, and I tend to reserve the band for a patient who I believe would not survive a leak from a sleeve gastrectomy. Cirrhotic, portal hypertension, cardiac cripple, cardiologist said needs their operation to lose their weight or they'll be dead in 6 months. That's sort of a patient. If you look at it's hard to get Australian mortality and morbidity. It's poorly recorded. It's clearly higher than what they say here in our own governing body, Medicare, 0.4% complications, 0.2% mortality. But essentially, we're not killing every patient who has the surgery. There is a risk. It's far less than 1% who die from the surgery, and we are creating morbidity if it goes wrong, but the morbidity is still low, and patient satisfaction scores are pretty high. For those Queenslanders out there, I'm sure you recognise this man, George Fielding. He pioneered obesity surgery in Queensland. He underwent his own lap banding 13 years ago and has kept 35 kilos off, and now still places the band in New York. And he's delighted with the results of resolution of his reflux, hypertension, lipids and asthma. He even has his own YouTube video you can watch if you wish. Sleeve gastrectomy is the new trendy one. Originally it was reported as just really chopping the stomach off at this level and leaving the antrum. However, my brother and I and several around Australia have been doing this extended sleeve where we removed the entire antrum. Why? In other words, you basically trim the whole stomach up. It stops weight regain, and if you look at the swallows after the operation, there's the pylorus, and here's the staple line, and the entire stomach has been trimmed. It's less than 200 mils. There's 85% reduction in ghrelin, so people think like skinny people for the first time in their life. They've eaten their smaller meal, and they're not looking at that skinny person who's left that beautiful food beside them for the first time in their life. It is very real, and it's reportable, and satiety levels are recorded. And so if we look at results of 700 patients with reduction of, with associated comorbidities, we've had no deaths, trained many fellows, and our results, pleasingly, show a 75% excess weight reduction out to 5 years. So we are showing that there are some really good results that can be achieved with this extended sleeve gastrectomy. And if you look at the results of the Swedish obesity study and extrapolate our own results so far, even though we are aware that the stomachs do stretch and there could be a reoperation rate, that it is encouraging that we are noting that we're expecting to have really good findings over the next 10 or 15 years. Sure, some patients are resistant for certain reasons. They have their sweet tooth, they don't exercise, they do other issues, but there may be a higher reoperation rate, but we're expecting good long-term results. And more importantly, satisfaction rates by the patient are encouraging, highly satisfied or satisfied. There's always a few, probably those who have had a complication, that are less satisfied with a leak rate of 1%. Finally, if you look at quality of life, just to touch on adolescents, their quality of life, if you're obese, is the same as if you're having chemotherapy or in a wheelchair. And if you look at after Roux-Y gastric bypass, as your weight comes down, all forms of quality of life improve for these young patients. Physical comfort, body esteem, psychosocial factors. So in summary, obesity, the evidence base suggests that perhaps it's strongly genetically determined, that diet, exercise and drugs don't appear as potent as we would like with respect to durable weight loss, that surgery is a durable remedy for significant weight loss, it is cost effective, it's very good at resolving the associated comorbidities, it's highly curable for early stage diabetes, and it seems to improve quality, longevity and quality of life. Thank you.